A, 20, a 67-year-old man, a 67-year-old man comes to the emergency department because of weakness of her left arm for a week. He occasionally gets lost in the neighborhood. He occasionally gets lost in the neighborhood, and over the past month had intermittent confusion about buttoning his shirt and putting on shoes and socks. He takes an oral hypoglycemic agent. He takes an oral hypoglycemic agent for type 2 diabetes mellitus and nifedipine for hypertension. Her blood pressure is 148 by 98. There is greater weakness in the left upper extremity. There is greater weakness in the left upper extremity than the right. Babinski sign is present bilaterally. Deep tendon reflexes and hyperactive. Deep tendon reflexes are hyperactive on the left. She states that the year is 1977 and the President Kennedy identifies a pen as the thing you write with and ink holder with the writing part on it. CT scan of the head shows cerebral atrophy and focal hypodensities in the periventricular and the subcortical area. Which of the following is the most likely diagnosis?
Ready?
Yes.
So it's multi-infravascular dementia. Multi-infravascular dementia is characterized by a subacute or chronic stepwise um, decline in cognitive functioning following vascular phenomena. For example, presenting as progressive loss of function after each cerebrovascular accident in a series of ischemic stroke. This factor for vascular dementia includes smoking, hypertension, diabetes, carotid and intracranial atherosclerosis disease, history of hypercoagulability at AFib and age. An ischemic stroke involves an event in which there is occlusion of blood flow at the cerebral artery by embolus or thrombus, causing focal neurologic deficits such as hemiparesis. Ataxia, apraxia, aphasia, and numbness. Signs of oculomotor neuron damage such as Babinski and also present CT scan of the hemi show evidence of prior ischemic events. Okay, next.
A 56-year-old man a 56-year-old man comes to the emergency department history of because of 24-hour history of left-sided facial weakness. 24-hour history of left-sided facial weakness. When his symptoms started yesterday, he noticed a sensation that felt as if wind was blowing near my ear. 10 hours later, he noticed that he was drooling from the left side of his mouth while he was eating soup. Upon awakening this morning, looking at the mirror, he noticed that left side of her face appeared sagging. He also had a 3-year history of holocephalic, dull holocephalic, non-pulsating headache, dull holocephalic, non-pulsating headache, and the sensitivity to the light. The patient has 30-year history of psoriasis. Medications are topical triamcinolone cream and monthly secukinumab injection. His aunt has rheumatoid arthritis, his sister has multiple sclerosis, and his paternal uncle has psoriatic arthritis. The patient works as a forest lodging supervisor but has not worked for the past 3 days because of headache. He has been sexually active with five female partners during the past 3 months. He does not use condoms. He is 175 centimeter tall and weight 70 kg, BMI 23. Temperature is 38 degrees Celsius, pulse 78 per minute, respiration 16 per minute, blood pressure 144 by 86. Fundoscopic examination cannot be done due to photosensitivity. Physical examination shows left-sided facial weakness with flattening of the nasolabial fold and left-sided facial weakness, flattening of the nasolabial fold, and loss of left frontalis muscle corrugation. There is nuchal rigidity. Exam results by hemoglobin 14, hematocrit 33, leukocyte 9200, platelet 532,000. Rapid plasma reagin RPR is positive. Glucose may be high. Sorry, glucose, serum glucose is 98 normal. Mm, CSF glucose 72, total protein 52, WBC 17, RBC 16. Which of the following studies is most likely to confirm the diagnosis?
He has syphilis. So is it syphilis? Syphilis is bacteria, right? Or is it fungus? It's bacteria.
Spirochetes, one of the spirochetes, maybe bacteria.
Then the CSF would not be like that. Um, that's kind of like meningitis. I don't know. I'm between the Borrelia and the viper venom, but I don't know what the viper venom does.
She has multiple problems.
Yeah, he has like syphilis and Bell's palsy and like psoriasis and I don't know, like a weird
If there is,
eye issue. I mean, I guess the main thing is the Bell's palsy and the eye and the sorry.
and the RPR positive,
Not really. I don't think the RPI positive isn't has anything to do here. The thing is the no, sorry, it's the Bell's palsy and the
psoriasis,
not really. She's treating it. And the forgot where I was going. But anyway, I guess it's the Bell's palsy. The Bell's palsy. I thought I saw something else. Never mind. Oh, the meningitis. Sorry, the meningitis because he has there is no rigidity and yeah, because the CSF does not portray like bacteria. They cannot be syphilis. It cannot actually be Borrelia. Okay. I feel like it's the viper venom thing. It's probably something weird like that. Okay, let's see. Ready?
yes.
Oh, it's Borrelia. Never mind. Uh, Lyme meningitis and Bell palsy are known. Lyme meningitis. Oh, Lyme can cause meningitis too. Yeah. Are known neurological complications of Lyme disease caused by Borrelia. Borrelia are transmitted following tick bites, most commonly from Exodus ticks. Initial manifestation of Lyme disease include the rash, which is a expanding rash with center clearing and targetoid appearance. It generally appears within 1 to 2 weeks of the bite. Left untreated, a subset of patients will develop disseminated disease that may result in Bell's palsy, meningitis, myopericarditis, and arthritis. Patients may diagnose clinically when characteristic rash is observed in the setting of known or probable exposure to tick in an endemic area. Serologic testing is controversial, however, it may be in support of diagnosis in later stage of disease. When necessary, a tiered strategy using ELISA and Western blot analysis testing Lyme antibodies may be used to diagnose the conditions. Patients with early localized Lyme disease are treated with doxycycline. Amoxicillin patients with neurologic disease, however, are treated with doxycycline or ceftriaxone. It's not dilute rostral viper venom time. It's used for the detection of lupus anticoagulant. Oh, really? Oh, anticoagulants, which may be indicated in antiphospholipid syndrome, characterized by recurrent miscarriages or vessel thrombosis in patients with SLE or autoimmune disease. Oh, so dilute Russell viper venom is not for a snake, it's for lupus. No, no, that.
It's for
It's not.
APAs, antiphospholipid antibiotics, for the
Oh,
diagnosis.
I thought it was a snake thing. Anyway. VGRL for syphilis and RPR tests are both non-treponema tests to screen for syphilis. In patients with positive testing, screening testing confirmatory testing should be done with FDA-ABS. There are many circumstances in which non-treponema tests will generate a false positive. They are sensitive, not specific tests. Okay, next.
A 22-year-old man is brought to the emergency. 22-year-old man is brought to the emergency department because of loss of consciousness after he struck his head when he dove into a shallow pool 30 minutes ago. He was rescued immediately and was unresponsive to voice and noxious stimuli for 5 minutes. He began to awaken at the scene. On arrival, he is alert and dizzy and vomits twice. During evaluation, the vital signs are within normal limit. There is a bruise in the middle of the forehead. Examination shows normal optic disc fundi, pupil response, ocular movement, muscle strength, and reflexes. He does not remember the event or coming to the hospital. He does not remember the event and or coming to the hospital. He is able to recall zero of the three objects after 5 minutes. He is oriented to person. 4 hours later, he is able to recall the three objects. After 5 minutes, her symptoms has resolved except for a mild headache. Which of the following is the most likely diagnosis? Ready?
Oh, sorry, one moment. I'm so strange my reflexes. Does not remember the event. He's oriented to person. 4 hours later, he's able to recall. The symptoms have resolved except for my headache. What does he have on the air? Facial bone fracture. Let me see. Says he has something on the head. Something on the head. Bruise in the forehead. Okay, ready.
Okay.
Mm, concussion. My traumatic brain injury, also known as concussion, commonly results in transient loss of consciousness, confusion, amnesia, headache, dizziness, nausea, vomiting, minutes after the injury. Symptoms that commonly develop within the following days include mood disturbance, photophobia, phonophobia, trouble concentrating, insomnia. Focal neurologic symptoms such as limb weakness and vision may indicate traumatic neurovascular injury. As such, all patients with suspected concussion should undergo a thorough neurologic exam and a subsequent and a subset of at-risk patients should receive neuroimaging, especially those demonstrating neurologic deficit. All patients should be monitored closely for 24 hours on neurologic deterioration, which may indicate the development of intracranial hematoma. To prevent cumulative brain injury, a second patients with concussion should return to their usual activity in a graded patient, beginning with return to school or work. Each day, a more intense activity can be introduced, like exercise community with sports contact after 1 week or more in uncomplicated and improving cases. Several critical decision rules exist to inform the need for neuroimaging following head injury. These rules are designed to be sensitive rather than specific, therefore, there are a few false negative cases when these rules are applied. Okay. It's not subdural hematoma may present with insidious onset of headache, lethargy, confusion, nausea, vomiting, seizures, and vision impairment. Chronic subdural hematoma most commonly occur in older patients. This young patient instead presents with acute onset of neurologic symptoms following a blunt injury, and it's not. I was confused with something else. Epidural, I guess. Epidural hematoma is classically associated with trauma to the median meningeal artery. It can present with initial lucid interval followed by deterioration of mental status. Patient can also develop symptoms of headache, vomiting, seizure, whatever. This patient demonstrate an improving rather than a deteriorating course. Epidural hematomas can rapidly expand, causing brain herniation syndromes. Okay, next. Next.
Yes, one moment, please.
Mm-hmm.
Okay. A 77-year-old man, a 77-year-old man is brought to the emergency department 8 hours after awakening, 8 hours after awakening with right-sided weakness and inability to speak. He takes digoxin for atrial fibrillation. His temperature is 37, pulse 88 per minute, pulse is irregular respiration 20 per minute, blood pressure 140/80. Examination show right-sided hemiparesis with greater or right-sided hemiparesis with weakness greater in the upper than the lower extremity, weakness greater in the upper than the lower extremity. His language is non-fluent and he has difficulty naming objects and repeating words. Difficulty naming objects and repeating words. His comprehension is mildly impaired. Carried ultrasonography shows less than 50% stenosis bilaterally. Which of the following is most likely to have prevented this condition?
Ready?
1 second. Yes.
Okay. So it is warfarin therapy. An embolic ischemic stroke um, involves an event in which a clot breaks off and travels to the brain, occluding blood flow at the cerebral artery. Emboli can come from proximal vessels, such as the internal carotid artery, or from atrial thrombus. This patient has AFib, which can predispose to atrial thrombus that can embolize and cause ischemic stroke. For this patient with AFib, an anticoagulant would be the most appropriate pharmacotherapy to help prevent ischemic stroke. Warfarin is anticoagulant. It interferes with carboxylation of coagulation factor. This occurs through the inhibition of vitamin K oxidase reductase, which is necessary for recycling vitamin K, an essential cofactor in the synthesis of coagulation factors in the liver. It's not severe carotid artery atherosclerosis and stenosis can also cause thromboembolic stroke. Carotid endarterectomy will be indicated for patients with greater than 50% to 70% stenosis after a TIA attack or non-disabling stroke. Current guidelines recommend liver. Okay, next.
A 55-year-old man with emphysema is brought to the emergency department because of 5-month history of weakness and fatigue in his legs. 5-month history of weakness and fatigue in his legs. His symptoms briefly improve a short distance if he walks a short distance, and worsen if he continues to walk. So his symptoms improve if he walks short distance, but worsens if he continues to walk. During the past 4 months, he has been unable to maintain erection and has had dry mouth. He has 5 year history of unstable angina pectoris. He has not recurrence of pain undergoing placement of two coronary artery stent 2 years ago. His medications are diltiazem, atenolol, low-grade aspirin. He smoked 2 packs of cigarette for 35 years. Pulse 68, respiration 18 per minute, blood pressure 122 by 78. Pulse oximetry on room air shows an oxygen saturation 96%. On pulmonary examination, breath sounds are decreased on the left side. Cardiac examination shows no abnormality. Neurologic examination show mild dysarthria in the lower extremity muscle strength 4 by 5 and 5 by 5 distally. Deep tendon reflex is 1 plus with repeat testing 2 plus. The remainder of the examination showed no abnormality. Which of the following is the most likely diagnosis?
Ready?
Is it Eden Lambert?
That's what I think. I mean, it doesn't say he has any um like sign of cancer, but I mean he smoked.
Okay.
I think so. Yes, Lambert-Eaton syndrome. This patient history of emphysema and smoking, as well as signs and symptoms of decreased breath sound in the left lung base, muscular weakness that improves with exertion, reduced deep tendon reflexes, and autonomic dysfunction like dry mouth, erectile dysfunction are concerning with Lambert-Eaton. Is an uncommon neurologic condition involving formation of antibodies to gated calcium channels in the neuromuscular junction, commonly as a paraneoplastic phenomenon associated with small cell lung cancer. We know what the voltage gated to blah, blah. In LEMS, antibodies against voltage gated to prevent terminal axon calcium influx and release of acetylcholine to the skeletal muscles. Patients classically display a triad of muscle weakness, depressed or absent deep tendon reflexes, and autonomic dysfunction. Muscle weakness and narrowfacial typically improve with exercise, as amounts of acetylcholine, blah, blah, blah. Autonomic symptoms may include orthostasis, decreased salivation, dry eyes, and erectile dysfunction. Didn't know that. Ocular and bulbar muscle symptoms may occur later in the disease following onset of proximal muscle weakness and may include dysphagia, diplopia, ptosis. The diagnosis is confirmed with nerve conduction studies and electromyogram with exercise testing. Mm,
Okay.
Next.
A 4-year-old boy is brought to the physician. 4-year-old boy brought to the physician by his mother because of 4-month history of sleepwalking. He goes to bed every night at 7 p.m. These episodes begin 1 hour. These episodes begin about 1 hour after he falls asleep and occur every 2 weeks. He never hurts himself or others while sleepwalking. Physical examination shows no abnormality. Which of the following is the most likely diagnosis?
Ready?
Yes, is it reassurance?
I think so. I'm not sure.
Okay.
Yes, it's reassurance. This patient demonstrates sleepwalking, a common parasomnia of childhood. Sleepwalking behaviors can range from intermittent quiet walking to frequently running around the house or behaving dangerous, like walking outside during a winter night. Polysomnography is indicated for dangerous sleepwalking or features suggestive of other comorbidities like snoring, suggestive of OSA. Um, yeah. However, for patients with infrequent or non-dangerous episode reassurance is indicated. For patients who leave their bed, environmental safety measures should be taken. Clearing obstructions from bedroom floor, securing windows, placing the patient on mattress on the floor. The patient should not be restrained as this may exacerbate the disturbance. It's not C, multiple sleep latency tests as assist in evaluation of narcolepsy. This patient does not demonstrate intrusion of REM sleep phenomena, cataplexy, or hallucinations. This psych assessment is not warranted. Sleepwalking is not associated. It's commonly an isolated symptom in healthy children. Next.
A 37-year-old woman comes to the physician because of 1 week history of numbness. Because of 1 week history of numbness of her left arm and hand. During this time, she also had poor short-term poor short-term memory and electric shocks that run down her back when he flexes his neck, like Larmit, isn't it?
I think so.
Okay. He reports two previous episodes of left arm numbness during the past year. The first occurred 6 months ago, and the lasted 1 week. The second occurred 4 months and lasted 6 days. She does not recall participated in. She does not recall what precipitated the numbness in the past, but she observed that the most recent episode began after she took a hot shower. She was successfully treated with Neisseria gonorrhea infection at that time of 18 years. Sensation to pinprick is decreased over the left forearm. The remainder of the examination shows no abnormality. Which of the following is the additional finding is most likely to be found in this patient? Is it MS?
Think so. Ready?
Yes.
Is the marination of spinal cord accent. This patient has prior history of self-resolving numbness and presents with new hand numbness, a positive Lermit sign, which is consistent with MS. MS is the most prevalent immediate immune-mediated demyelinating disease and may present with episodic or non-progressive focal neurologic dysfunction. Episodic or progressive, sorry, including sensory loss, optic neuritis, weakness, bladder or bowel dysfunction, cognitive impairment. These factors include female with white 20 to 40, residence in temperate climates, and ancestry with HLA-DR2 and haplotype. Ac- According to the McDonald curve for MS, patients must have evidence of demyelinating lesions that are separated in time and location, fluid attenuated inversion recovery. MRI sequences typically show white matter hyperintensities in the periventricular and subcortical white matter cerebellum and spine. Leukonoral bands and immunoglobulins include indicating immune overactivation can be found in the CSF, not necessary for diagnosis. Treatment includes steroid for symptomatic management of acute flares and long-term modifying treatments such as interferon or monoclonal antibody. Cooling techniques like cold drinks, lightweight clothing, air conditioned iPad, cooling suits may improve heat-related exacerbation. Lifestyle modifications that apply to all patients, such as balanced diet, regular exercise, and avoiding excessive alcohol, are also recommended to decrease your inflammation. Next. Next.
Yes, sorry.
No worries.
Okay. A 46-year-old woman, 46-year-old woman comes to the office because of 3-week history of moderate low back pain. She works as a personal care assistant. She works as a personal care assistant and says she works as a personal care assistant and says her back pain began after he transferred a patient. She has had difficulty sleeping because of the pain despite treatment with ibuprofen and acetaminophen with codeine. The patient adds that a dull headache over the she has a dull headache over her entire head for the past 2 days. Medical history is remarkable for hypertension and type 2 diabetes mellitus. Medications are lisinopril and metformin. She is 5 feet 5 inch tall and weight is 82 kg. BMI 30 kg per meter square. Vital signs within normal limit. Physical examination discloses hyperlordosis and paraspinal muscle spasm. Muscle strength 5 by 5 and deep tendon reflex are normal throughout. Sensation is intact, gait is slow and antalgic. Which of the following is the most appropriate next step in the management? Moderate.
Ready?
As it is 3 week. Wait 1 second. I everything. Okay. Pain. Is it physical therapy or
I don't know because I if I was gonna pick physical therapy. I pick physical therapy, but then she has the headache, which I don't know if that counts as a neurological issue. So we should do X-ray. Then she already tried ibuprofen and acetaminophen. So I don't know if we should up the thing and just do oxycodone since she still has the pain. But it's less than
so?
4 weeks. It's still normal. So I don't really know.
There is another thing. She is female and BMI is 30. Is it IIH?
Oh,
Why
oh,
headache? Should we think on that way?
oh.
Maybe back pain is the distractor.
Mm,
Is it possible? Because but physical examination shows hyperlordosis and paraspinal muscle spasm.
yeah, I don't think back pain would be the distractor. But now that you're saying it, mm.
It looks like.
No, I feel like if they will give more signs of like papilledema and all these things. But maybe I don't know. I don't know. Now
Okay,
that you,
let's pick physical therapy.
okay, let's
Then
see.
see what happens.
Yeah, it's physical therapy. Acute low back pain lasts up to 4 weeks and may be associated with overuse or exception. Clinically, patients
This
may experience,
CMS has plenty of clues. Like
yeah,
for IIH to happen, for BMI should be how much? Like BMI should be more than what? Is there
um,
anything like that? Like BMI should be more than this or that?
there is not usually BMI should be, but usually. 30, I still consider it a little
BA,
bit
BMI
more,
is more than 30.
more
I
than
have,
30.
so
But I
it actually fits if you want
no,
to.
not really. I feel like the IIH question are pretty like flexible.
IIH comes with IIH. She's female, one risk factor, and BMI is 30
It's,
or more than 30.
it's not really that high. And then IIH question, they will give you exactly the whole papilledema and is like the head.
They have given a signs like headache. Not clear papilledema. Yes, the IIH can cause bilateral papilledema. There is bilateral optic disc edema.
Yeah, not just that, they will give you the signs of intracranial pressure. Like they will give you a lot of.
Headache is the intracranial pressure.
But the questions I've seen the IIH, it's pretty clear. Like with
Yes,
questions
yes,
we've
true.
seen that like it's IIH. They will tell
Yes,
you the toxic thing. It will be like so clear. So that's why I didn't even thought about it. But here is still I was also confused because yeah. But I guess the key is like it's only 3 weeks. It's not 4 weeks. So it's still normal back pain. It's still not.
yes, it is still. So, like, how many weeks we should wait for back pain?
For if it's less than four, like four or less, like it's still normal. Now it's normal, so you do the NSAID and physical therapy and blah 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 all these things. But if less than 4 weeks and they give you like the neurologic symptoms, so you're gonna know it's gonna be like cannot pee or whatever, all these things. Then you have to do the X-ray.
X, is
I
it
think
X-ray or MRI?
I
Like,
think MRI when you think
MRI is when there is cord compression. When MRI is done.
when there is core compression, when there is abscess, like the epidural abscess or whatever. When there is, you think infection, or like the what we had a question yesterday. Yeah, the infection or the IV drug use kind of
Okay.
thing. Yeah,
Like epidural spinal abscess, that one.
kind of. Yeah, the epidural abscess, or what. That's where you do MRI. But I think if not, then you start with just the X-ray or something. Um,
Okay.
but here is it's still 3 weeks. So
Yes.
clinically, patients may experience pain with movement and paraspinal tenderness. Oh, and then another thing that my tutor told me when they give you the word paraspinal tenderness, that means it's just like strain, like she carried something and hurt her back.
Yes,
This is
true.
not normal. Yeah. In the absence of neurologic symptoms, okay, most cases will resolve with conservative management, which includes physical therapy and sets, massage, therapy. Certain red flags, signs, and symptoms should trigger further eval, especially if there is concern for infection, malignancy, spinal cord compression, compromise, vertebral fracture. These include but are not limited to new fevers, IV drug use, focal neurologic, blah, 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 like saddle anesthesia, bowel incontinence, whatever. Progressive lower extremity neurologic symptoms, current or recent cancer history, advanced age, steroid use, trauma. For this patient, the most appropriate next step is physical therapy. Okay, it's not lumbar puncture because that's for meningitis. It's not MRI of the entire spine, I guess, and X-ray of the lumbar spine should be reserved for patients who present with red flag signs and symptoms to evaluate for evidence of infection, malignancy, spinal cord compression, vertebral fracture. Yeah, I guess vertebral fracture will be for X-ray. For otherwise healthy patients with back pain that has persisted less than 4 weeks, imaging studies do not generally change management. Oxycodone therapy should be reserved for severe refractory cases of acute low back pain. Opiates have not generally been shown to be effective in the management of musculoskeletal back pain and may create dependence along with hyperphagia or withdrawal medication. Okay,
So
next.
MRI and X-ray for if there is any red flag sign of the
Yes,
spine,
yes,
and oxycodone for severe refractory pain.
yes,
A 16-year a 16-year-old girl A 16-year-old girl is brought to the physician because of 6-month history of episodes of visual loss in her right visual field that occurs every 2 weeks. The visual loss occurs suddenly and lasts for about 5 to 10 minutes before gradually resolving. She occasionally has severe headache, vomiting, and loss of balance. As the visual loss is resolving, she has no history of serious illness, takes no medication. Her blood pressure is 115 by 75. Examination shows intracranial nerves including visual acuity, visual field and ocular motility. The remainder of the examination shows no abnormality. Which of the following is most likely location of the onset of her symptoms?
I have no idea what the hell
Visual
is.
loss. Right.
Ready?
Yes.
Okay, so it's left occipital cortex. At least I know it was occipital. After the cassetting of the hadoptic chiasm, retinal ganglion cells, axon carrying information from the right visual field traverse the optic radiations and synapse at the lateral geniculate nucleus. Neurons from the lateral geniculus travel to the primary visual cortex via optic radiations. Lesions rostral to the optic chiasm lead to ipsilateral deficits of one eye, whereas lesion caudal to the optic chiasm cause contralateral visual field defect, involving both eyes as in this patient. Okay. Does this patient right visual field deficit is attributable to left-sided area of dysfunction called caudal to the optic chiasm? Migraine is a common condition that typically presents with recurrent primary headaches. Some patients experience an aura before or during the headache, which may present with visual field defect followed by perception of scintillating shape or lines or paresthesia. For some patients, the migraine auras occur in the absence of headache. The pathophase of migraine aura involves the spread of cortical depolarization, the sequential depolarization of neuron, which typically originates in the occipital cortex. This depolarization produces visual field defects. It's not the left or right temporal cortex. Lesion may interrupt the inferior branch of the optic radiation. They present with contralateral superior quadrantopia. Superior quadrantopia. Okay, makes sense. Visual defect described as a wedge shaped aura. Migraine auras originate in the occipital cortex, not the temporal cortex. Okay, next. Next.
Mm, wait. Why this is left? Why
It
it
says
is?
that I
Yes.
don't know if I understood well, but it says that it's after the optic chiasm, so it's contralateral. If it was before the optic chiasm, so that's the optic chiasm. If the issue happens before, then it's ipsilateral. If it happens after, then it's contralateral.
Okay. Now I got it. Is it the tumor with the tail?
Oh, let me see.
Am I right?
I think so.
Let's take a chance. without reading the question.
Okay,
Okay, let's see.
let's see. So you are right. It's meningioma, common benign CNS tumor derived from meninges that occur along the surface of the brain and spinal cord, often in parafalcine region. They occur in females more than males and are associated with NF2 and MENT1. Patients may be asymptomatic or experience seizure or focal neurologic deficits related to tumor location. Meningioma are typically benign but can be malignant. Malignant meningioma may grow rapidly, leading to symptoms of increased intracranial pressure, such as postural headache, nausea, papilledema. Meningiomas appear as well-circumscribed extraction outside of the brain masses that compress the parenchyma. They show uniform enhancement on imaging. Definitive diagnosis requires histologic exam of tissue, which will show spindle cells arranged in word pattern with some memory. Treatment may include antiepileptics or surgical resection to alleviate the tumor mass effect. Often, periodic surveillance is all that's necessary. Okay, next.
Next.
Or you want to take a break?
Sorry.
Can we take a quick 5 minute break?
Yes,
Just five.
yes.
Okay, just 5 minutes. Promise.
Okay. No problem. Take 10.
Okay. Okay.
Okay. A 57-year-old man, a 57-year-old man with alcohol use, a 57-year-old man with alcohol use disorder is brought to the emergency department by his family because of progressive confusion and lethargy over the past 8 hours. The family says that he has not had any alcohol for 16 hours. He had cirrhosis of liver and esophageal varices. He had cirrhosis of liver and esophageal varices. Uh, examination shows examination shows jaundice, primary erythema, spider angiomata. Examination shows jaundice, primary erythema, spider angiomata, ascites. The arms are held extended, and there are irregular lapses of postural tone. There is diffuse hyporeflexia, cranial nerve appears intact. His stuporous, responding only to vigorous noxious stimuli by cursing for a few seconds before drifting off again. During examination, he has an episode of hematemesis. Stools are melanotic. Which of the following is the most likely diagnosis? Is it flapping?
I think so. Ready?
Yes.
Who is hepatic encephalopathy? Hepatic encephalopathy is commonly associated with decompensated liver cirrhosis. Signs of hepatic encephalopathy include confusion, stupor, asterixis, tremor, and myoclonus on physical exam. Hepatic encephalopathy results from accumulation of ammonia produced by colonic bacteria. Serum ammonia concentration in patients with hepatic encephalopathy may be increased, though this is not necessary for diagnosis. Treatment for hepatic encephalopathy include rifampicin and loflactulose. Rifampicin is a gut-selective, non-absorbable antibiotic with activity against gram-positive, gram-negative bacteria. It acts on the beta subunit, blah, 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 to inhibit bacteria synthesis and is bactericidal, so kills the bacteria. Lactulose is degraded by colonic bacteria to create acidic environment, therefore converting ammonia to ammonium, which cannot be readily absorbed to the gut wall, is then excreted in the feces. lowering the total body level. Next. Next.
Yes, yes.
Mhm.
A 67-year-old woman comes to the physician. A 67-year-old woman comes to the physician because of 5-year history of shaking her hands. Because of 5-year history of shaking her hands, which has worsened during the past 4 months. She has hypercholesterolemia, hypertension, coronary artery disease, and type 2 diabetes mellitus. Our medications are simvastatin, losartan, insulin, and 81 milligram of aspirin. Vital signs are within normal limit. Physical examination shows a slight tremor of the head. There is rapid low amplitude tremor when the hands are outstretched and no tremor when the hands are rest. Muscle strength is 5/5. Deep tendon reflex are normal. Our hemoglobin is HbA1c is 8.2%. Which of the following is the appropriate next step in the management?
Ready?
One sec.
Mhm.
Let's do Okay. Is it essential tremor, isn't it?
Yes. Essential tremor is a common adult action tremor that most commonly presents as a bilateral tremor of the upper extremities. In general, action tremors are exacerbated by activity and sustain anti-gravity postures and improve by rest. Essential tremors specifically are exacerbated by stress and improved by small quantities of alcohol. The tremors may progressively involve more body regions over time, including the extremity, head, and voice. Pathogenesis of essential tremor is unknown, though its common is heritable. Heritable. Propranolol and primidone are both effective first line. Propranolol has fewer non-drug interactions and better tolerated. Adverse effect, however, primidone, which is metabolized to phenobarbital and methylmalonamide, is equally effective. Patients may respond to one drug and not the other. Okay, next.
Yes. A 32-year-old man comes to the physician. A 32-year-old man comes to the physician because of 2-month history of deformity of the toes of the right foot. He has not had pain in his toes, but he has discomfort in the sole of his foot. 3 months ago, he underwent excision of plantar fibroma of the right foot. Examination showed hyperextension of the three medial digit at the metatarsophalangeal joints. Examination examination shows hyperextension of the three medial digit at the metatarsophalangeal joints. The surgical excision is well healed. Which of the following is the most likely cause of this patient finding? You know the answer?
Medial, yeah, I'm between B and D. I don't remember. The medial three digits are the lateral plantar or the medial plantar. I guess it will be the medial plantar. Medial plantar. Yeah, I guess it will be the medial plantar. I'm between B and D. Okay, ready?
Yes.
Where am I? Yeah, laceration of the medial plantar nerve. A plantar fibroma is a benign growth of the sorry, a plantar fibroma, a benign growth of the underlying plantar fascia that may cause pain with ambulation and can be treated with surgical removal. The medial plantar nerve arises from the tibial nerve and is an association with the medial plantar artery supplies the distal foot. Distal foot. Cutaneous branches of this nerve travel along and through the plantar aponeurosis, supplying the medial plantar foot. Muscular branches supply the abductor hallucis, flexor digitorum brevis, and lumbricus. Injury or laceration of these nerves, such as during removal of plantar fiber, will prevent flexion of the medial digits, as described in this case. If not, stretch injury of the lateral plantar nerve may result in impaired sensation of the lateral foot and impairs function of the quadratus plantae or abductor digiti minimi muscles. Okay, next.
So plantar fibroma. Lots of different things.
Different things, yeah.
Okay. Next. A 47-year-old woman. A 47-year-old woman is brought to the emergency department. A 47-year-old woman is brought to the emergency department by relatives because of 2 hour history of confusion. Because of 2 hour history of confusion and hallucination, she has 20-year history of alcohol disorder. She has 20-year history of alcohol disorder and has been numerous times in the emergency department for seizures and traumatic injuries sustained when she was intoxicated. 3 weeks ago, she sustained a 3 weeks ago she sustained a tibial fracture. Her relatives report that she stopped drinking 3 days ago because she has been unable to obtain alcohol. She takes no medications. Her temperature is 38.9 degrees Celsius, 102 Fahrenheit. Pulse is 116 per minute. Respiration is 24 per minute. Blood pressure is 160 by 110 millimeter of mercury. He appears disheveled, malnourished. Physical examination shows no abnormalities. Neurologic examination shows resting tremor. Neurologic examination shows a resting tremor of both hands. On mental status examination, she is uncooperative, agitated. She is uncooperative, agitated, and says that she sees spider and insect. She sees spider and insect around the room. She is disoriented to person, place, and time. Which of the following is most likely diagnosis?
Ready?
1 second.
Mhm.
Is it due to alcohol withdrawal, like delirium tremens?
I think so. I'm not sure, but I think so.
Okay.
Okay, so is delirium tremens. Alcohol increases the CNS activity of GABA, the main neurotransmitter. Broad discontinuation, the main inhibitory neurotransmitter. A broad discontinuation of alcohol leads to sympathetic excitatory excess. Uncomplicated alcohol withdrawal typically present with tremors, anxiety, restlessness, headache, nausea, and diaphoresis. Which can occur hours after stop using alcohol. If left untreated, alcohol withdrawal can be complicated by seizures and alcohol hallucinations like auditory visual hallucination. Delirium, most life-threatening complication, Typically begins like 2 days to 1 week after patient has twin. Presentation of delirium includes confusion, disorientation, fluctuations in consciousness, disorientation, agitation, visual or auditory hallucination, and autonomic instability. Alcohol withdrawal is managed supportively with benzo to address agitation and prevent or treat the symptoms of withdrawal, along with fluids, nutritional supplementation, and assessment of vital signs. Next. Next.
A 83-year-old man is brought to the clinic by his wife because of rapidly progressive memory loss during the past year. He was diagnosed with Alzheimer's disease 1 year ago. His wife is worried that he is not acting like her mother, who died of Alzheimer's disease. He no longer recognizes family or friends and requires 24 hours assistance. He also claimed to see small children dressed in bridal star clothes in his bedroom. When he wakes from a nap in the afternoon, the wife says he frequently acted out in his dreams in his 40s. He has no history of serious illness, takes no medication, vital signs are within normal limit. Examination show uh, Physical examination shows mildly stooped posture and moderate cogwheel rigidity but no tremor. She has slow shuffling gait. On mental status, flat effect. He recalls 0 to 3 objects after 5 minutes, cannot draw a clock face, and attempted to draw a square with lines instead. Which of the following is most likely diagnosis? Rapidly progressing. Is
Ready?
it Parkinson disease causing dementia,
I
or
I
is it
know
Alzheimer? There is
it's
no
definitely
Alzheimer.
not like ready.
Okay.
It's Lewy body dementia. It's a common cause of the degenerative dementia.
There is hallucination also. He is seeing the Easter small children dressed in bright Easter. Isn't it hallucination? Visual hallucination.
Mm-hmm.
I missed it.
Degenerative. Mhm. And is associated with the presence of eosinophilic intracytoplasmic inclusion of alpha-synuclein called Lewy bodies. Lewy bodies dementia is associated with rapid progressive dementia with fluctuations in cognition, attention, and arousal. Additional symptoms include hallucination and hypersomnia. Patients may have REM sleep behavior disorder, which is a loss of atonia during REM sleep. Patients may have Parkinson features, including bradykinesia, resting tremor, rigidity, gait abnormalities. Patients with Lewy body dementia are treated symptomatically. Cognitive symptoms may be treated with cholinesterase inhibitors. Uh, Behavioral symptoms may respond to antipsychotic, and Parkinsonia feature may respond to carbidopa levodopa. It's not, where was I? Parkinson presents with dysfunction of voluntary movement in the form of bradykinesia, resting tremor, rigidity, and postural instability. Dementia may occur late in the disease course, but motor symptoms are predominant in Parkinson's disease. Progressive supranuclear palsy and atypical Parkinson disorder is neurodegenerative disease related to tau Positive neurofibrillary tangles in the basal ganglia cortex and brainstem. Patients typically present at an average of 65 with gait instability, oculomotor deficits, mm, vertical gaze palsy, frontal lobe deficit, bradykinesia, and muscle rigidity. Okay, next.
Okay, next. What is your diagnosis?
Oh, sorry, I never look. Um,
Multiple ring enhanced English, but it is
I don't think that's ring enhanced. Is that ring enhanced issues?
okay. You want me to read the? Okay, I'm
Yeah,
reading
please.
this. A47. He is using Marshall notes. What is Marshall note?
What is what?
Look at the question paper. Like you have seen the above. Marrell's note. Okay, sorry, Marshall, not Marrell. Is there in
Where?
eh, the above the new free 120
Uh-huh.
ECFMG?
Oh, it's here.
Yes. What
I don't.
what is this? What is Merrill's notebook?
I don't know. Maybe it's the name of the person that took it. I don't
Okay,
know.
maybe. Okay. A 47-year-old woman comes to the physician because of 1 month history of episodes of involuntary rhythmic jerking of her right arm. The episodes usually last 1 minute and has and have occurred on 6 occasions. 20 years ago, she was hospitalized following a motor vehicle collision because she had loss of conscious because she had loss of consciousness for 30 minutes and a confusion for 6 hours. She has had diffuse throbbing headache since the collision. The headache, which resolved 650 milligram of aspirin, have decreased in frequency but continue to occur once a month. During the past month, she has had a new onset persistent. She has had new onset persistent left-sided frontotemporal headache. Her only medication is the aspirin as needed. She lives in Mexico and commutes to the USA daily for work. He comes from Mexico to USA daily.
Mm-hmm.
Okay. Examination including neurologic examination show no abnormality. CT scan of the head without contrast is shown. Which of the following is most likely cause of this patient's episodes of arm jerking? It
Ready?
is not the punctured hemorrhage, is it? If it
Punctate.
hemorrhage, if it is punctured hemorrhage, then it is DI, diffuse axonal injury. And I'm not thinking. Is it toxoplasma or cysticercosis?
That's what I'm thinking. I'm between the two also.
He lives in Mexico, so he does some, but multiple ring-enhancing, not that. Okay, maybe it's cysticercosis. Okay,
Ready?
yes.
Is cysticercosis. Yes, cysticercosis. This patient presents with new onset seizures. Where is
Tinea
the seizure?
solium.
It's new onset seizures, headache, and CT scan findings showing calcified lesions in the brain parenchyma which is suggestive of cysticercosis. Neurocysticercosis is a CNS infection caused by Potassium solium that is most commonly found in endemic rural region of Latin America, Asia, and Africa. Symptoms include headache, seizures, signs of increased intracranial pressure, and rarely altered vision. Headache, seizures. Okay. Some patients are asymptomatic, while other patients may present with muscle of subcutaneous nodules. Typical manifestation on CT and MRI include cystic, enhancing calcified lesions in the brain, parenchyma, meninges, ventricle, spinal cord, and orbit. The scolex overhead may also be seen on imaging. Treatment includes symptomatic management of increased intracranial pressure and seizures, antiparasitic therapy, and steroids. It's not toxoplasma. What is F?
Okay.
Wait, I'm trying to read F.
Yes.
Toxoplasmosis often presents with headache, seizures, focal neurologic deficit, and systemic symptoms. Cerebral toxoplasmosis is often found in severely immunocompromised patients, specifically patients with AIDS. CT scans classically shows numerous ring enhancing lesions, not the cystic ring enhancing lesions. Numerous ring enhancing lesions, not the cystic ring enhancing. How do I know it's cystic? Calcified lesions seen in this patient. I want to see neuro. What's the difference between neuro? Okay, no. Let me see. Toxoplasma ring enhancing lesion. What does it look like? And what's the day? Okay, so it's bigger and it has the. Okay, got it. Okay, next.
Toxoplasma's ring enhancing is slightly bigger than the
Yeah, it's slightly bigger.
next.
Mhm.
A 50-year-old man comes to the physician because of progressive left foot drop over the past 2 weeks. He has had persistent pain in the left. He has had persistent pain in the left buttock, uh, posterior thigh, calf for a month. The pain is aggravated by sitting. Examination shows examination shows um, examination shows weakness of the left toe extensor and the anterior and the posterior tibial muscle. Sensation is decreased over the anterolateral portion of the shin and the anterolateral portion of the shin and the dorsum of the foot. Deep tendon reflexes are normal. Which of the following is most likely location of this lesion?
Between lumbar nerve and peripheral nerve. Lumbar. Let's go with peripheral nerve. Ready?
Yes,
Oh, what is my thing? So is lumbar nerve. I knew it. In degenerative disc diseases, in degenerative disc disease or disc herniation, pressure on the spinal nerve leads to back pain and paresthesia, numbness, pain, and a weakness of the lower extremity. One of the most common areas of involvement is the L5 nerve root, which typically presents with back pain that radiates down the lateral aspect of the leg into the foot. Strength is decreased in dorsiflexion, toe extension, and foot inversion and inversion. Sensory sensory loss is confined to the lower leg and dorsum of the foot. Diagnosis may be made clinically or with the assistance of electromyograph or MRI. Patients may benefit from trial of anti-inflammatories as well as physical therapy. Patients with severe disease may benefit from surgical consultation. It is not peripheral nerve injury such as the fibular nerve may be, may be the result of fibular head fracture. Patients may present with pain sensory changes and foot drop. However, these patients will not experience referred pain from the buttocks. Mhm. Okay,
I
next.
don't understand.
Um, do not understand it either. I guess they don't consider the lumbar nerve a peripheral nerve. I don't understand it.
There
I mean,
is nothing. They give like muscle area of the weakness, anterior thigh, sorry, anterior shin and dorsum of the foot. Um, I don't get it actually. Why this is lumbar nerve? Okay. Is
which one do you think it was? What do you think was the answer? Sorry. What answer did you pick?
I pick lumbosacral plexus. Why plexus? But
Why
but
not
lumbosacral plexus will come with cauda I am wrong. But why
okay.
lumbar nerve?
Lumbar nerve root?
Is it like that things L3 for that chart like L345 lump? You got my
Can
point.
you,
Cervical, there is two chart cervical and one is lumbar chart in the
mhm.
U world.
um
Okay, let's leave it. If we
no, I
start,
think no, I think it's just because I was confused between peripheral nerve. I knew it wasn't lumbosacral, the plexus, because the plexus will involve, like you said, the cauda equina. It will involve a lot of things. Um,
yes,
but I was between peripheral nerve because the things that you just mentioned, the dorsum of the foot, whatever, it's innervated by the tibial nerve too. I think tibial or fibular, no fibular nerve. So I thought that's why it was peripheral and stuff. But they're saying that it could have been fibular nerve, but the fact that they mentioned that it involves the buttocks, the butt, and it's coming from the spinal cord to involve the buttocks and it go all the way down. The fibular nerve doesn't go all the way to your spine. It wouldn't affect your spine, your buttocks and all that. It would just affect the things that they mentioned here. So the fact that it involves the buttocks, that's where it becomes lumbar nerve, you know, like a nerve that starts in the spine, like lumbar or sacral or all that. I think that's
okay.
what it is. Mhm. Next.
The thing, uh, nerve root. Okay, I got it. Now I got it. A previously healthy 72-year-old man. A previously healthy 72-year-old man is hospitalized for evaluation of the lightheadedness, palpitation, and mild dyspnea on exertion over the past 2 weeks. He has hypertension well controlled with thiazide diuretics. He has hypertension well controlled with thiazide diuretics. Examination shows atrial fibrillation and a rapid ventricular response 5 days ago after oral warfarin and digoxin therapy is begun. His pulse is maintained at less than 100 per minute. Echocardiography shows normal values and left atrial size. He is discharged with continued warfarin therapy. 2 weeks later, he had 2 weeks later attempts at electrical cardioversion is unsuccessful, which of the following pharmacological measures is most likely to prevent cerebrovascular morbidity in this patient?
Ready?
1 second. Okay.
So it's continued warfarin only. AFib can be recognized on ECG as irregular, narrowing, um, irregular narrowing complex arrhythmia lacking P waves. Uncoordinated atrial contractions and tachycardia results in diminished left ventricular filling during diastole, which results in a decreased cardiac output. AFib can also lead to formation of thrombus in the atrium. When a thrombus occurs, breaks off and travels to the brain, blood flow can be concluded and causing embolic stroke. For this patient with AFib, an anticoagulant would be the most appropriate pharmacotherapy to help prevent ischemic stroke. Warfarin is an anticoagulant that interferes with the blah blah blah. This occurs to the it is not B. Adding antiplatelet agents such as aspirin or another anticoagulant such as heparin would not result in significant additional protection against ischemic stroke and will necessarily increase the risk of bleeding. Patients are typically placed on one anticoagulant medication to prevent cerebrovascular morbidity in the setting of AFib. Next.
Okay. A 68-year-old woman with a 68-year-old woman with a pulmonary embolism is hospitalized for heparin treatment 2 hours after blood is drawn. 2 hours after blood is drawn from antecubital vein. She has pain on the forearm and numbness. She has pain on the forearm, numbness of the thumb, index, and long fingers. Numb index and long finger. Motor impairment is normal except for weakness of the thumb opposition. Which of the following is most likely anatomic location of the compression? Of opposition করতে পারতেছি।
Ready?
Yes.
So it's median nerve at the elbow. The median nerve supplies motor fibers to the majority of the muscles of the anterior forearm, along with muscles in the thenar eminence and the first two lumbrical muscles. Transmit sensory input from the anterior palm, the anterior and distal aspect of the digits 1 through 3, to the radial aspect of digit 4. It supplies motor fibers to the radial half of the flexor digitorum profundus. The median nerve can be injured in the setting of supracondylar humerus fracture, carpal tunnel syndrome in the wrist, or laceration along its course. Median nerve injury can cause symptoms depending on the location of the lesion, causing palsy distal to the injury. In this patient, injury of the antecubital elbow region will cause symptoms in the forearm and hand. Median nerve palsy can result in impaired wrist flexion, thumb opposition, flexion of the lateral fingers, and impaired sensation in the anterior forearm, thenar eminence, and volar and dorsal distal aspect of the lateral three
3 and
digits of,
half.
yeah.
Why it is not in the intercarpal canal?
Compression of the median nerve at the intercarpal canal, also known as carpal tunnel syndrome, will initially lead to pain and paresthesia In the first three digits and may progress to hand weakness. Sensory and motor symptoms of the forearm and arm will be atypical, as the forearm will not be affected.
Okay.
Okay, next.
His forearm is affected, so elbow is the answer. These things are a bit hard. Uh, for a an 82-year-old woman with end-stage dementia Alzheimer's disease is admitted to the hospital because of failure to thrive. She has been non-communicative for 14 months and is now bedbound. He has had decreased oral intake, resulting in 8.6 kg weight loss over the past 3 months. She appears chaotic. She is 165 centimeter, 5 feet 5 inch tall, weight is 45 kg, BMI is 17 kg per meter square. BMI is low,
Mm-hmm.
isn't it? Uh, she responds to painful stimuli but not to her name. Her daughter states that the first durable, she is the first durable proper power of attorney for healthcare decision and is concerned that her mother is starving. The daughter requests that a feeding tube may be placed in order to begin artificial nutrition and hydration. Which of the following is the most appropriate next step?
Ready?
Yes.
So it's review the risk and benefits of enteral nutrition with the daughter. Surrogate decision makers, legal guardian, durable power, whatever, next of kin, are responsible for medical decision making for patients who lack capacity, like right now. The use of enteral tube feeding in patients with advanced dementia has been found consistently not to result in prolongation of life or increased quality of life, and may result in harmful complications related to aspiration, pneumonia, tube clogging or dislodgement, infection, skin ulceration. Despite this evidence, enteral tube feeding is still often offered to patients with advanced dementia, particularly when a particular patient's surrogate decision maker favor aggressive intervention. Family members who request invasive interventions during end of life care often may not understand the invasive nature and potential complications of the requested intervention. When family members request an intervention that is not beneficial and maybe harmful, or thoughtful and empathetic discussion of the risk and lack of benefit is most appropriate. Okay, it's not place tube and beginning a therapy is inappropriate given the lack of demonstrated benefits in this population. And the requesting written documentation of the daughter's power is that is not necessary at this time and may lead to confrontation. As discussed above, a review of the potential risks and benefits of enteral nutrition is most appropriate and likely to dissuade the daughter from this intervention. Next.
Okay. A 42-year-old woman is brought to the physician because of 3-day history of excessive sleepiness, loss of appetite, dizziness, double vision, and staggering gait. She has a seizure disorder and is poorly controlled with phenytoin and major depressive disorder treated with fluoxetine. She has a history of substance use disorder and poor medication compliance. She is sleepy, but cooperative people are equal but reactive to light. There is nystagmus in all fields of gauge. Strength and sensation are normal. She has dysmetria on heel to shin maneuver. She is unable to perform tandem walk, deep tendon reflexor 3 plus bilateral babesiosis and is absent. Which of the following is most likely to confirm the diagnosis? Uh, Ready?
Mm, sure. Measurement of phenytoin levels. Know that. Phenytoin is an anticonvulsant medication with many cytochrome P450 system interaction and adverse effect. This adverse effect may occur at therapeutic serum concentration, but are commonly those dependent and mediated by toxic serum concentration secondary to a narrow therapeutic window. This patient phenytoin concentration likely increased due to the inhibition of CYP2C19 by fluoxetine and the setting of substance use leading to irregular fluoxetine administration pattern. Common adverse effects include neurotoxicity, nystagmus, diplopia, ataxia, secondary to cerebral atrophy, lethargy, and fibroblast stimulation leading to gingival hyperplasia, coarse fasciitis, and hirsutism. Less commonly, phenytoin can cause cardiac arrhythmias, megaloblastic anemia, and Stevens-Johnson syndrome. This patient's serum phenytoin concentration should be measured. If increased, phenytoin should be discontinued, and if severely increased, hemodialysis should be considered. Hmm.
Next.
Oh, wait. It's not MRI of the brain commonly used to investigate the cause of acute neurologic changes. Well, MRI is necessary for this patient at this time, and there is likely an installation for this. Okay. Next.
A 47-year-old woman is brought to the emergency department after sudden onset spinning sensation, and vomiting that began when she awakened this morning. She had mild cough 1 week ago. She is currently taking medication there. She is lying still on the stretcher and is unwilling to move. Our temperature is 37 degrees Celsius, pulse 100 per minute, respiration 20 per minute, blood pressure 110 by 75. 10 seconds after she turns into 10 seconds after she turns her head to the right, um, toward the left, there is a jerk nystagmus, the first common to the right. Neurologic examination show no abnormality. Which of the patient most likely has abnormality of which of the following set?
Ready?
Yes.
So it's peripheral vestibular system. Dizziness and gait instability carries a broad differential diagnosis and is often divided into central, peripheral, and secondary causes of symptoms to determine a likely diagnosis. Central causes include cerebrovascular accidents such as ischemic and hemorrhagic stroke, tumors on the brainstem and cerebellum, infarction involving the vestibulocochlear nerve, and multiple sclerosis or similar diseases. Peripheral causes include BPH, vertigo, labyrinthitis, mania, disease, endolymphatic fistula, or temporal bone fractures, tumors, or lesions. Secondary or systemic causes can include electrolyte imbalance, hypovolemia, cardiac arrhythmia, infection, vitamin deficiency, This patient rarely has labyrinthitis and inflammation of the inner ear, often involving the vestibulocochlear nerve, um, and often preceded by upper respiratory or ear infection, causing symptoms, vertigo, ataxia, nausea, vomiting, hearing loss. Treatment is supportive along with the exclusion of emergent causes of vertigo and ataxia, as the condition is typically self-limited. Next.
Okay. 2 days after admission to the hospital for right lower lobe pneumonia, a 57-year-old woman has progressive confusion. She has 10-year history of hypertension treated with atenolol. She has smoked 1 pack of cigarette daily for 40 years, drinks 3 to 4 glasses of wine. She has been receiving IV ceftriaxone 0.9% sodium chloride. She has decreased appetite and has little oral intake since admission. She appears restless and is oriented to the person but not the place or time. Her temperature is 37.2 degrees Celsius, pulse is 68 per minute, respiration 12 per minute, blood pressure 130 by 86 millimeter of mercury. The neck is supple. Examination of the skin shows no abnormality. There is nystagmus and lateral gaze bilaterally. Crackles are heard on the right lung base. Abdominal examination shows no abnormality. The patient is unable to walk because of unsteady gait. Labs result hemoglobin 13, MCV 98, leukocyte normal, segmented neutrophil 65 normal, monocyte 5%, lymphocyte 30%. Mm,
What does she have?
Is it
Mm,
thiamine? She is
mm,
alcoholic.
that's the only thing that makes sense. Ready?
Yes.
Oh, yes, vitamin B1. Patients with alcohol use disorder typically show a significant vitamin B1 deficiency due to poor nutritional intake, thiamine, and absorption in impaired cellular utilization of vitamin. Over time, thiamine deficiency can result in damage and atrophy of the mammillary bodies visible on MRI, which manifests as Wernicke encephalopathy. To prevent Wernicke, patients with sustained alcohol use should be given oral thiamine supplementation. In patients presenting with acute intoxication, should generally be given parenteral thiamine. Typical clinical presentation of Wernicke encephalopathy, triad of ultimate study of thermoplegia and ataxia. Oh, yeah, we can see the triad here. The symptoms of Wernicke are reversible but increase the risk of developing Korsakoff in chronic alcohol user if not immediately treated with high-dose thiamine. Korsakoff syndrome is a reversible condition that features psychosis, anterograde amnesia, and the consequent tendency to confabulate. Yeah, next.
Next. A 90-year-old man comes to the office with his wife because of 4 week history of mild pain. She has not had pain or weakness in her upper extremity. In her upper extremity, she has no history of serious illness, taking no medication. The patient's wife says that the patient wife says that he awakens nightly to use bathroom. She drinks 2 glasses of wine with dinner. Vital signs are within normal limit. Muscle strength 5/5 in the upper extremity and lower extremity bilaterally. Deep tendon reflex are 1 plus in the upper and the lower extremity bilaterally. Is decreased. Sensation sensation to vibration is decreased over the toes bilaterally. Sensation to cold and touch is intact in all extremity. Is unable to tandem walk. Which of the following is most likely explanation of this patient's physical findings?
Ready?
1 second.
Mhm.
Okay, ready.
So if normal aging, this patient has physical exam findings consistent with normal aging. Normal aging includes a slow decline of executive functioning, attention span, and problem solving after 70 years old. The CNS is affected greatly by aging process, and there are characteristic findings consistent with normal aging. One of the most common neurologic changes to occur is the loss of vibratory sensation, primarily in the distal extremity. Other findings include decreased to absent deep tendon reflexes, especially in the ankles, decreased pupillary response to light, presbyopia, and decreased hearing. As the patient ages, the gait often becomes broad-based and the stride shortened. Changes associated with sleep include a decrease in REM sleep and sleep onset latency, an increase in nightmare awakening. It's crucial for physicians to be familiar with these changes and be able to distinguish from pathologic findings. It's not osteoarthritis, it's a common degenerative condition that is found primarily in elderly patients and frequently affects the weight bearing joints of the hip and knee. Pain is often worse at the end of the day and after activity. Osteoarthritis does not cause deep tendon reflex, decrease deep tendon reflex and decrease sensation. Peripheral neuropathy has many causes, including metabolic, toxic, autoimmune, and hereditary neuropathy. Symptoms include paresthesia, oops, or pain and extremity weakness in the stocking gloving distribution. Okay, next.
Next. What is your diagnosis?
Hmm. I was gonna say central retinal artery occlusion, but
It is papilloedema, isn't it?
yeah, but you can also see that in acute angle closure glaucoma. You can also see that in idiopathic intracranial. So yeah, we have to read.
Or we can say, okay, a previously healthy 77-year-old woman is brought to the physician by her husband 2 hours after the sudden loss of vision in her right eye. Sudden loss of vision in her right eye. She has frequent headache for the previous 2 weeks, occasional jaw pain when chewing. Our blood pressure 135/85, visual acuity 20/400 on the right, 20/20 on the left. Examination of the right eye show RAPD, relative afferent pupillary defect. Fundoscopy examination of the right eye is shown. Which of the following is most likely diagnosis?
You see that we couldn't not by the picture here.
Yes. Is it
Hmm.
temporal arteritis?
Most likely. That's why I don't. Sometimes I'm scared of just going to the picture because here it could have been a lot of papilledema is a sign in a lot of things. Ready?
Yes.
With temporal arteritis, I don't think we need to read this. I think we got it.
Yes, next.
Okay.
A previously healthy 37-year-old man is brought to the physician because of today history of increasingly severe low back pain that began after he fell when trying to get out of the truck. The pain radiates to the back. The pain radiates to the back on his right leg. That the same leg has become increasingly numb during the past 12 hours. He has not been able to void spontaneously and has had two episodes of urinary incontinence. On examination, straight leg raising test is positive on the right, strength of the ankle dorsiflexion and the extensor hallucis longus muscle 3 by 5, muscle strength in the lower extremity 5 by 5 examination. Neurologic examination showed decreased sensation over the dorsum of the right foot. Which of the following is most likely diagnosis?
Ready?
1 second. Is it Corda-Equina syndrome?
That's what I'm thinking. Either that or tibial, but
I
tibial
think
wouldn't
that it
probably.
is Corda.
Yeah.
Okay.
Okay, let's see. Yes, Coda-Equina syndrome occurs as a result of compression of the spinal nerve roots comprising the corda equina. Often such compression occurs due to malignancy, trauma, dissemination, spinal stenosis, spinal epidural abscess, valvular hematoma. Symptoms include lower extremity numbness, weakness, paralysis, hyporeflexia, perineal anesthesia, fecal incontinence, overflow incontinence. Emergent MRI of the lobosacral spine is indicated to investigate the cause of cardiac syndrome and to determine the necessity of surgery. Initial treatment for patients with epidural spinal cord compression and neurologic deficits includes symptomatic treatment, pain control, and steroid therapy to operative therapy. High dose steroid therapy is helpful as a bridge um, to definitive therapy and have helped control the pain and may transiently improve neurologic function, secondary to decreasing edema at the site of cord compression. Okay, next. Next.
Yes. A previously healthy 57-year-old woman is brought to the emergency department by ambulance 30 minutes after an episode of unconsciousness lasted for 30 seconds. Her husband says that on to the walking to the lobby during the intermission of a play, she complained that she felt hot at lightheadedness and fell to the ground unconscious. She then had a 10 seconds episodes of shaking her arms and legs. On awaking, she has nausea and sweating. She has no headache, chest pain because before the episodes of urinary or fecal incontinence during these episodes. She has no history of cardiac disease, chest pain, diabetes mellitus, hypercholesterolemia. Examination shows no abnormality, arrhythmic strip paramedics at the scene show sinus bradycardia and fast degree AV block. Which of the following most likely diagnosis?
Ready?
Yes.
So it's vasovagal syncope, damn it. Syncope is common in presenting finding with numerous causes. Okay. Vasovagal syncope is caused by disordered autonomic nervous system response with increased parasympathetic and decreased sympathetic activity. This results in an acute decrease in peripheral vascular resistance with simultaneous bradycardia, decreased cardiac output, and inability to maintain perfusion to the brain. Symptoms often follow specific triggers such as standing or long for long periods of time, heat, intense emotion, the sight of blood or pain. The onset of symptoms is typically gradual over several seconds and associated with nausea, lightheadedness, dizziness, and visual disturbances, pallor, and diaphoresis. A careful history that evaluates for provoking factors in physical exam can guide further diagnosis. N is essential for differentiating Beshevaga from other potential causes such as cardiac syncope, seizures, hypoglycemia, and transient ischemia. The diagnosis is clinical, though a diagnostic evaluation is often performed to exclude other diagnoses. Till testing may reproduce vasovagal symptoms and is helpful when diagnosis is uncertain. For most patients, avoidance of risk factors is the only necessary treatment. Drop attack is a non-specific term that refers to a sudden fall without an associated loss of consciousness, which may occur for a variety of neurological, vascular, or orthopedic reasons. Okay, next.
Next,
Next.
an otherwise healthy 47-year-old woman comes to the physician because of 2 week history of worsening left-sided headache, the pain which is worse, the pain which is worse when she is physically active and when she lies down, and is partially relieved by 370 milligrams of aspirin. 1 month ago, she was involved in a motor vehicle collision in which she was restrained. She was the restrained driver. Her car was hit broadside from the left. She says that she hit her head out of the window. She has brief episode of consciousness and a bump later developed the left side of her head. She refused medical attention from paramedics. Her pulse is 60 per minute, respiration is 12 per minute, blood pressure 140 by 70. Deep tendon reflex are mildly increased in the left. Deep tendon reflex are mildly increased on right compared to the left. The remainder of the examination show no abnormality. An injury to which of the following structure is most likely cause of our signs and symptoms?
Mm, mm, he has upper respiratory upper mainly increase on the right. And between breaching veins and middle cerebral artery. Bump on the left of the head. A
You are
breaching vein.
thinking subdural.
I'm thinking either subdural or middle cerebral because she has open motor neuron signs. So subdural is usually takes time to develop. So when she hit her head, middle cerebral, how would you injure the middle cerebral? I mean, middle
Middle
cerebral, it can cause open motor neuron, but how would you injure it on the?
middle cerebral artery comes with like paralysis of like contralateral paralysis of the face and the upper limb, isn't
Mm,
it?
no, I think the middle is the up. lower limb and
No, ACA is the lower limb. MCA is
oh,
the
well,
upper limb and face.
I thought I sent you. Was it the homunculus thingy? Let me see.
Yes,
I just sent
you
it to
can
you.
say.
Let
You
me
can
see.
see ACA is the lower limb and MCA is the upper limb and the face.
ACA, yeah, ACA is the lower. Okay, ACA is the trunk and lower limb. Okay, and MCA is the face and upper limb. So it can actually be the face here, but wait, she has what? Deep tendon reflexes are increased in the right compared to the left. I don't know. I feel like how would you injure the MCA in the motor? I'm going to with the bridging veins. Ready?
Okay,
Yeah. Okay. So is the bridging veins. Yeah, because how you injure the MCA there? Sharing of the bridging veins is in the subdural space is the cause of subdural hematoma. A trauma, the use of anticoagulant, physical abuse, alcohol use disorder, cerebral atrophy, malignancy, blah blah blah, increase the risk of SDH. In imaging, SDH appears as crescent shape collection abutting in the dental surface of the skull, not bound by suture lines. In some cases, the HA may be large enough to compress the adjacent brain parenchyma, displacing the cerebral hemisphere. Thus, presentation can include subacute onset headache, focal neurologic impairment that start a seizure, initiation, and signs of increased intracranial pressure, such as vomiting, papilledema. Patients may manifest oculomotor neuron signs, examination findings such as, yeah, we know that. Elderly patients are at risk for cerebral atrophy, which places them are, yeah. In the setting of minor trauma such as falls, can result in shearing of the veins leading to hemorrhage. In treated, the AGA may continue to grow, the intracranial compartment is blah, 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 blah. We know that when such mass affect is present or at risk for developing surgical interventions, blah blah blah, craniotomy can be done. It's not middle cerebral artery traumatic injury is rare. Deficits are more often seen in the setting of stroke. Okay, occlusion of the MCA artery leads to contralateral hemiparesis and contralateral sensory deficit of the face and upper extremity. Occlusion of the middle MCA supplying the dominant hemisphere leads to aphasia, while occlusion of the middle MCA supplying the non-dominant hemisphere leads to hemi neglect. Okay, next.
so why not MCA?
Because how you gonna injure MCA just on that's one thing. How you gonna injure MCA is inside of the brain, and she had the motor vehicle accident where she bumped her head, so the bridging will be closer. And then what else? I don't know what else there. What else will be?
Okay,
Because MCA also
yeah,
can come with upper motor neuron, so I don't think that can make a difference here.
yes. Okay, last two questions. A 77-year-old man is brought to the emergency department immediately after 30 minutes of spinning vertigo, 30 minutes of spinning vertigo and right facial and upper extremity numbness that occurred while he was shopping at a grocery store. He has similar episodes of spinning vertigo and slurred speech 1 month ago that lasted for 1 hour. He has type 2 diabetes, mellitus, hypertension, coronary artery disease. Medications include atenolol, clothalidone, glyburide, aspirin. He His pulse is 86 per minute, blood pressure 150 by 90 millimeter mercury. There is horizontal left upbeating nystagmus that worsens with left gaze. Sensation is absent to pinprick over the right side of her face. Hearing is reduced bilaterally to a finger rub. Cardiac examination shows bilateral supraclavicular carotid fluid A grade 2 by 6 systolic ejection murmur is heard at the left base, heard at the cardiac base. Muscle strength is normal throughout. Deep tendon reflex is 3 plus. A Babinski sign is present. Bilateral Romberg sign is positive at a broad base. Romberg sign is positive and has broad-based gait. Which of the following is the most likely diagnosis? Romberg's positive. Sensory ataxia.
Ready?
Okay.
So it's vertebrobacillar insufficiency. Did not see that one coming. Vertebrobacillar insufficiency is often caused by atherosclerosis leading to decreased posterior circulation, most commonly at or near the vertebrobacillar artery junction. Symptoms of vertebrobacillar insufficiency can include vertigo, lightheadedness, disequilibrium, ataxia, and nystagmus due to transient decreased blood supply to the vestibular nucleus. Patients can have difficulty walking or lean while standing upright without support, Romberg sign. Open motor neuron signs such as hyperreflection and Babinski point to a central cause of this patient vertigo. Vertebrovascular insufficiency can be transient, such as with transient ischemic attack, or cause infarction of the lateral medulla. Patients can also present with loss of pain and temperature sensation in the ipsilateral face and contralateral extremities. Acoustic neuroma presents with symptoms of hearing loss, vertigo, and ataxia, often slow in onset and progressive over a subacute chronic period. Acoustic neuroma may exert mass effect on cranial nerves within the proximal or invert the nerves from which they arise, often the facial, vestibulocochlear, and adjacent nerve, resulting in facial asymmetry and diminished hearing. Or tinnitus, bilateral hyperreflexia and Babinski's are most suggestive of uh, vertebrovascular insufficiency. It's not carotid stenosis and cause decreased flow to the brain or embolic events causing cerebrovascular ischemia. Patients can have carotid brain examinations. I thought here they had a carotid brain. Okay, next. Next.
Okay, tell me your diagnosis.
Oh, wait for the next question. Okay, one moment.
Yes. Okay, I'm reading the question.
Oh, okay. I thought it was an image.
No, no, without image. ESR is high, CK normal, 3 hour history of. Okay, a 72-year-old woman comes to the physician because of 3 week history of generalized malaise and aching pain in his shoulder and the hip. The shoulder is more severe. The shoulder pain is more severe when she combs her hair, and her and the hip pain is more severe when he rises from low chair. He has had no weakness, sensory loss, changes in the bowel and the bladder. She takes vitamin D, calcium supplementation, alendronate. She is 157 centimeter tall, weight is 57 kg, BMI 23 kg per meter square. Her temperature is 1 plus. Her temperature is 37, pulse 80 per minute, blood pressure 140 by 70. Cranial nerves are intact. Muscle strength 5 by 5 throughout. Deep tendon reflex 2 plus. Diffusely except for 1 plus. In the ankles, Babinski sign is absent. Lab testing show ESR under 12. CK is 20. EMG show no abnormal. Which of the following is the most appropriate system? Okay.
Okay. So it's prednisone, PMR, polymyalgia rheumatica, inflammatory condition characterized by proximal muscle and joint pain, stiffness, and increased inflammatory markers. Yeah. If untreated, muscle weakness may occur from diffuse atrophy. Symptoms such as fatigue are commonly noted. It's most common in patients over 60, and some patients are associated temporal arthritis. Signs of temporal arthritis, we know that the diagnosis of PMR is based on um, clinical features, and treatment is with prednisone for up to 1 hour. It is common for patients to respond to prednisone almost immediately, blah, blah, blah. Okay, done.
Okay.
Okay, I will see you then say next